The following podcast is part of a certified educational activity titled Modern Practice Principles in Lung Cancer. First find the targets, then treat with precision. A concise guide for biomarker testing and EGFR-targeted therapy in non-small cell lung cancer. Access the entire activity and complete the post-test at peerview.com/KRC860. Downloadable slides and practice aids are also available.
Hello and welcome. My name is Dr. Joshua Sabari. I'm a thoracic medical oncologist at NYU Langone Health Perlmutter Cancer Center in New York. And we're going to talk about treating EGFR-mutated non-small cell lung cancer, a concise how-to guide to select and sequence therapies, as well as managing adverse events in this patient population. So let's jump in. The goals for today are to augment your knowledge of the evidence supporting the use of EGFR-targeted therapies and combinations in the first and later line settings for patients with EGFR-mutated non-small cell lung cancer. I also want to equip you with the skills for developing individualized treatment plans for patients with EGFR-mutated non-small cell lung cancer based on all the relevant factors. So let's talk about the upfront treatment in metastatic non-small cell lung cancer with classical EGFR mutations. So what are some of the considerations and questions that go through my mind when meeting a patient with an exon 19 deletion or L858R exon 21 EGFR mutation? So first off, does the subtype of the EGFR mutation matter? Now, how important is the demonstration of overall survival benefit? We know that's the king in clinical trials for our patients. What if the patient has a high burden of disease or, sites of disease that are concerning, such as the liver, bone, or CNS? What if the patient is older or frail or has a poor performance status, ECOG performance status of 2 or worse? Or what if they have different comorbidities? So let's look at some of the data, and this is all well known to you. This is the FLORA trial, international randomized phase 3 study of first-line osimertinib, a third-generation EGFR TKI, compared to a first-generation EGFR inhibitors here, gefitinib and erlotinib. Initially published in 2018, we saw median progression-free survival for osimertinib 18.9 months versus gefitinib or erlotinib about 10 months. And in 2020, we saw the update overall survival, an impressive 38.6-month median overall survival for osimertinib versus first-generation inhibitors about 32 months, leading this to become the standard of care in the first-line EGFR mutation population setting. Now, how do we build upon that? How do we think about moving the needle forward for our patients? So we'll talk about the Mariposa trial as well as the FLORA-2 trial, which look at combination strategies building upon the successes of third-generation EGFR TKI. So in the Mariposa trial, this is a randomized phase 3 study of amivantamab, an EGFR and MET bispecific, in combination with lazertinib versus osimertinib. There was a third arm of lazertinib for contribution of component. And what we saw was a positive progression-free survival benefit, 23.7-month median for ami-laz versus 16.6 months for osimertinib. And, quite impressive. And, when you look at this population and patients with or without baseline liver metastasis, you saw an equal benefit for both of these patient populations. Again, these are patients with high burden of disease. When you looked at patients with or without brain metastases, you did see a significant improvement in activity in patients with brain metastases. So median progression-free survival, 18.3 months for ami-laz versus 13 months for osimertinib alone. And remember, osimertinib is a therapy that we think has very good CNS penetration. Now, if you look at those patients without CNS metastases, those patients in general do far better. So median progression-free survival for ami-laz at 27.5 months and 19.9 months for osimertinib alone. Now, we just recently saw a press release for the overall survival benefit exceeding 1 year. We don't have the full data yet, but the chemotherapy-free regimen of amivantamab and lazertinib met the final pre-specified secondary endpoint of overall survival, demonstrating both a clinically meaningful and statistically significant improvement in overall survival versus the standard of care, which was osimertinib. And that improvement is expected to exceed 1 year. So we look forward to seeing that data presented at an upcoming meeting. Now, what about FLORA-2? FLORA-2, also a very interesting regimen. This looks at the combination of osimertinib plus chemotherapy versus osimertinib alone. The idea that using a combination strategy may be better than using a single third-generation EGFR TKI. And in this randomized phase 3 study, those patients receiving osimertinib plus chemotherapy had a median progression-free survival of 25.5 months versus osimertinib alone of 16.7 months. It is important to note that there was a benefit in progression-free survival, but what about overall survival? And we'll talk a lot about that in this patient population. When we look at the same subsets we just talked about in Mariposa, in those patients with liver metastasis, you did see an improvement with the addition of chemo to osimertinib at 19.5-month median progression-free survival versus osimertinib alone at 11.1 months. And clearly, those patients without liver metastasis did far better, but still a benefit for those patients receiving osi chemo over osimertinib alone. What about those patients with CNS metastasis? Here, too, we did see a benefit for those patients receiving osi chemo, 24.9-month median progression-free survival versus osimertinib monotherapy at 13.8 months. And clearly, if patients did not have CNS metastasis, those patients in general did far better. But what's interesting is the delta is not as much. So if you did not have brain metastasis, osi plus chemo, carboplatin pemetrexed, 27.6-month median progression-free survival versus osimertinib alone of 21-month median progression-free survival. So important to think about these patients and the risk, the burden of their disease, and would they benefit from a combination strategy with amivantamab and lazertinib or osimertinib plus chemotherapy over osimertinib alone. So what are some other considerations and questions? What if a patient lives remotely? We don't have this problem here in New York City, but, let's say someone lived 10 hours away from your clinic. And also, how do you assess and consider the AE profile of these different agents in combination? And we know that if patients live far away and don't have great access to cancer centers, it's going to be more difficult to manage and mitigate some of these adverse events. So we'll talk about managing toxicity profile with some of these agents. Now, going into the adverse events, let's focus first on the Mariposa regimen. So if you look at the Mariposa regimen, first off, amivantamab and lazertinib was safe. Most of the toxicities were grade 1 and 2, and interestingly, the most common toxicity was the infusion-related reaction, seen in about 2/3 of patients. We know we can mitigate that by using dexamethasone prophylactically, and hopefully in the near future, moving towards a subcutaneous formulation, which will completely eradicate the infusion-related reaction. There are then EGFR-related toxicities, the most common being paronychia and rash. And interestingly, those need to be mitigated. So we know that prophylactic steroid creams, emollients, ceramide-containing topicals are also very helpful. And sometimes even using, prophylactic antibiotics such as doxycycline or minocycline can be helpful in this patient population. But very close monitoring of patients' skin is going to be important. Educating patients on prevention of infection and breaking that cycle of inflammation and infection are critical. We then also see some MET-mediated toxicities, most commonly hypoalbuminemia and peripheral edema. Again, more common than with osimertinib alone. Interestingly, diarrhea here, the one toxicity that looks like ami and lazertinib are actually better than osimertinib alone. And the rate of interstitial lung disease equal in both populations at about 3%. So how do we prevent some of these toxicities? So first off, with the infusion-related reaction, we saw data presented at ESMO 2024 from the SKIP-IRR study that looked at prophylactic steroid, 2 days before, 1 day before, using dexamethasone prior to the infusion of amivantamab can actually prevent or decrease the rate of infusion-related reaction, about a 3-fold reduction, 22.5% for dexamethasone 8 milligrams 2 days before, a day before, and the day of, versus 67% IRR in the standard management population. And this is something that I have adopted in my clinical practice and seen the rate of IRR drop dramatically in the clinic. More recently, we saw the data for Paloma-3, and this was exciting data looking at subcutaneous amivantamab versus IV amivantamab, both in combination with lazertinib. And this was in patients with refractory EGFR-mutated non-small cell lung cancer. And what's interesting here is we were looking at a PK equivalent. So the primary endpoint was subcutaneous amivantamab similar in its pharmacokinetic properties as IV amivantamab? And what we saw is that they were very similar. They also had very similar activity. But what was exciting is when we looked at overall survival, there was an improvement in subcutaneous amivantamab over IV amivantamab. And again, it's an exploratory endpoint, but we're now pursuing this on a larger frontline study to try to better understand the utilization of sub-Q amivantamab in combination with lazertinib. And when you look at, sub-Q amivantamab with lazertinib, and you look at the rates of the different toxicities, the rate of the IRR dropped dramatically. So we know that subcutaneous formulations far better tolerated than the IV formulation, with an IRR rate of 13% for subcutaneous amivantamab and 66% for the IV amivantamab. All the other toxicities were relatively similar, in my opinion. But what's important on this study is that we did do prophylactic anticoagulation with oral anticoagulants, and what we saw was a dramatic reduction in the rate of venous thromboembolism in this patient population. So also something that I'm commonly doing in my patients in the frontline setting receiving amivantamab and lazertinib, prophylaxis with anticoagulation for the first 4 months of therapy. When you look at the FLAURA2 adverse events, mostly they're chemotherapy related. So things like neutropenia, thrombocytopenia are common. Again, mostly grade 1 and 2. There are some grade 3 events, but in my opinion, more paper toxicity. We all have a lot of experience giving chemotherapy. And then there are other, sort of skin toxicities that you see with the combination over osimertinib alone. So what are some considerations and questions here? Who would we select a more aggressive regimen using AMI and lazertinib or, osimertinib plus chemotherapy? Well, we talked already about those patients with L858R. What about co-mutation status, P53? We know that there's a benefit for escalating therapy in those patients. And what are the potential roles and uses for measuring and monitoring ctDNA? We don't have any prospective data here, but these are, retrospective endpoints we looked at. Now, when we look at the relevance of P53, we've seen this across multiple retrospective studies now, that P53 co-alterations portend a poorer prognosis. And when we look at the P53 status in Mariposa, amivantamab and lazertinib, we know that about 50% of patients had a P53 alteration, and that's what I would see in my clinical practice. And those patients who received amivantamab and lazertinib who had a P53 co-alteration did far better, median progression-free survival of 18.2 months versus those receiving osimertinib alone of only 12.9 months. When you looked at those who were TP53 wild type, the delta was less dramatic. Amivantamab and lazertinib, 22.1 month median progression-free survival, and osimertinib, 19.9 months. Again, these are not prospective endpoints. These are really exploratory, retrospective analysis of the data collected. Same thing when we look at FLAURA2. What is the impact of baseline TP53 alterations? And we actually see very similar data emerge here, that P53 alterations up front, alteration at baseline, there does seem to be a benefit to receiving OSI chemo over osimertinib monotherapy in this population. And what is the value here of monitoring ctDNA dynamics in the EGFR mutant population? Well, we know in those patients with detectable baseline ctDNA, usually correlating with high burden of disease, those patients tend to do better when they receive combination therapy. Here showing amivantamab and lazertinib at 20.3 month median progression-free survival over osimertinib alone at 14.8 months. And in those patients who do not clear their ctDNA at 9 weeks, we know those patients portend a very poor prognosis, but clearly do better if they receive combination strategies with amivantamab and lazertinib. Median progression-free survival here 16.5 months versus osimertinib alone at 9.1 months. So I think ctDNA is emerging as an interesting biomarker in this population. Very similarly, on the FLORA-2 trial, baseline detected EGFR mutation in the peripheral circulation was a prognostic factor. And those patients receiving ACCME who had detected ctDNA did better than those patients receiving osimertinib alone. So how do we then think about the second-line therapy, so selecting sequential therapy in a patient who's already received frontline regimen with an EGFR mutation? And here, when you think about some of the considerations and questions, why did they progress on first line? What did they receive in the front line? That's really going to help sort of think about what the options are in the second line setting. So here we're looking at the MARIPOSA-2 data. MARIPOSA-2 is a randomized controlled trial of amivantamab plus chemo versus chemotherapy alone. And here you saw a progression-free survival benefit for ami-chemo over chemotherapy alone, leading to an FDA approval. And this is the standard of care in the second-line setting. I really don't think there's a role anymore for chemotherapy alone in the second line. Really, amivantamab plus chemotherapy has an improvement in progression-free survival in this patient population. And, here's an update on the overall survival at 18 months. 50% of patients were alive receiving ami-chemo versus 40% of those patients receiving chemotherapy alone. Again, this is ongoing, and we look to see the final overall survival data at an upcoming meeting. What are some of the other agents in this space? Well, there's a HER3-DXd, the HER3 antibody drug conjugate with a topoisomerase 1 payload. This is the HERTHENA Lung 01 study, and we see a broad reduction in tumor volume in patients who are heavily pretreated. Interestingly, HER3-DXd at 5.6 mg per kg, also a positive phase 3 study versus chemotherapy alone. And then more recently, the Tropion Lung 05, dato-DXd, which is a TROP2 antibody drug conjugate, here being studied in a phase 2 specifically for patients with driver mutations. We see about a 45+% response rate in those patients with EGFR mutations. So really an exciting potential opportunity, again, in the later line setting. And we saw a press release very recent of a pooled analysis of the Tropion Lung 05, as well as the Tropion Lung 01, which is a randomized second-line study, not exclusively in EGFR, but pulling the driver mutant population. We know that there is potential activity in this population, and we look forward to seeing the FDA ruling on this regimen as well. So let's jump into implementing current treatment standards in patients with EGFR exon 20 insertion mutations. Now, these are a relatively rare set of mutations. We probably see this in about 5 to 10% of those patients with EGFR mutations, and we know that EGFR exon 20 insertion mutant patients do not respond well to third-generation EGFR TKI. So we really start to need to think outside the box for this patient population. So what are some of the considerations and questions that one may have in a patient with newly diagnosed EGFR exon 20 insertions? How was the insertion detected? Was it detected? We know that NGS is far better than using a PCR-based assay. And, are the different insertion mutations responding differently to different therapy? And we'll look at some of that data shortly. So the Papillon study is a randomized phase 3 study of amivantamab plus chemotherapy versus chemotherapy alone in the frontline setting. And here you see the progression-free survival positive study, 11.4 months for ami-chemo versus 6.7 months for chemotherapy alone. Hazard ratio here impressively 0.395. So receiving ami plus chemo reduced the risk of progression or death by 60%. This has now become the standard of care in the frontline setting. FDA approved back in March of 2024. And, interestingly also, if you look at the response rate, much higher response rate for amivantamab plus chemo in that 70% range versus chemotherapy alone in that 40% range. What about in patients with amivantamab in pretreated exon 20 insertion mutated non-small cell lung cancer? So this is in the second line setting, and here we saw a response rate of 40% with a median progression-free survival of 8.3 months. There is an FDA-approved label here in the second line, but in my practice, if I identify a patient with exon 20, I would use ami chemo in the front line and not use this in the second line setting, potentially using other targeted therapies in development and clinical trial in that space. When we look at the long-term outcomes observed in patients with amivantamab in the Chrysalis trial, this is in cohort D, in patients pretreated who have EGFR exon 20 insertions, we see an overall survival median of 23 months with a median progression-free survival of 6.9 months. What are some of the other emerging tyrosine kinase inhibitors being developed? Well, there are 3 studies ongoing now in the frontline setting: zipalertinib plus chemotherapy versus chemotherapy. We also have a frontline study of sunvosertinib, an EGFR TKI versus chemotherapy. And lastly, furmonertinib versus chemotherapy. These have also been studied in the later line setting, and we've seen dramatic response rates in that 40 to 50% response rate. So I hope to see combinations in the near future, as well as novel therapeutics that have superior CNS penetration. Well, thank you for your attention and appreciate your time.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from Janssen Biotech Incorporated, administered by Janssen Scientific Affairs, LLC. Both are Johnson & Johnson companies. To access all materials for this activity, visit peerview.com/KRC860.